So we're now opening up to questions for our panel. There should be representatives from Nolex who've got the microphones up and down the room. If you can pop your hand up and introduce yourself and where you're from and who your question's directed to. Thank you. I think there's a question at the front there.
Good morning, everybody. Is that switched on? Yeah.
I think so, yeah.
So thank you for all those really, really interesting talks this morning. Just fascinating. My name's Julie Bryan, and I'm from an organisation called Trimedica, based in Belfast, as you may guess by my accent. So we're in the medical device industry, supplying to health services all across the world. So I have a question just really about how things are being reconsidered now in the choice of medical devices. So the question really is, how have the learnings of the pandemic altered how medical device selection teams, medical device committees, how are they assessing medical devices to come into the hospital differently now, particularly in terms of the ease of cleaning the devices, or even the degree that the devices may come into contact with the patients? I would love to hear your feedback on that question.
I'll answer that in a slightly general way, but the principles always remain the same, that a manufacturer must always consider how the device will need to be decontaminated if it's a device that's used between patients. But I have to say a far bigger agenda is sustainability. You know, we need to start thinking now about how we can move away from just using things and throwing them away. The amount of carbon that is consumed in generating healthcare products, particularly PPE, is shocking, and we cannot really afford to carry on doing this to the planet. So I know that the supply structures, certainly within the UK, really have that as a key part of their agenda. And the principles of keeping patients safe in terms of decontamination just simply remain the same.
Hello, my name is Shumi Matarike. I'm from West Suffolk Hospital in the IPC department. I was wondering if anybody could address, I know this was a talk done by the ladies from the RCN, but I was wondering if anybody would be able to address the elephant in the room about the FFP3 masks. Because of supply and demand, we've been told we can get whatever we can get, and people were supposed to have sessional use of things like FFP3 masks. Now we've just been told that it should not be worn for more than an hour at a time. Is there any guidance change where FFP3 masks, like tangible guidance that we can see, or what exactly are we supposed to be doing with FFP3 masks?
I won't necessarily give you the same opinion as Rose Gallagher. So this is my personal perspective, and having reviewed quite a lot of the evidence, because I was a member of the independent AGP panel, so I am familiar with quite a lot of the evidence. I think what is commonly overlooked is the assumption is that because COVID is transmitted by aerosols, and clearly aerosols have a part to play in the transmission of COVID, but droplets do too. And in fact, if you're looking at quantity of virus that you'll be exposed to far more virus in a droplet than you will in an aerosol, because an aerosol is tiny. The other thing that's commonly overlooked is the assumption is if it's aerosol transmitted, the only protection is an FFP3. And that is not what the evidence shows. What the evidence shows is that a standard surgical face mask, particularly if it's well-fitting, provides almost as good protection as an FFP3. And actually, many of you will know that because you have spent the last 2 years walking about your hospitals in surgical face masks, and that has protected you. So it isn't a zero-sum game. It's not, unless you're wearing an FFP3, you're not going to be protected. You will have good protection through using a well-fitting surgical mask. And I would suggest that the important thing to do, which Rose did talk about and Fiona did talk about, is about risk assessment. So it's about using FFP3s where there is a particular risk. So that might be a patient, particularly early in the course of their disease, when they're emitting the highest viral load, if they are coughing or if you're requiring close prolonged contact with the patient, then those are situations where FFP3 are clearly more likely to be required. Or for procedures where there's known to be an increase of emission of aerosols. So that would be my view on the situation with FFP3. In terms of guidance, I don't think the guidance has changed because essentially that's what the evidence shows. If you look at the epidemiological evidence, so I know we talk a lot about models, but the trouble with models is they're only as good as the data that you put in them. And so interpreting evidence from different sources, so using epidemiological data that shows actually what happens and how people acquire infection in practice, is also very, very important.
Okay, thank you. Any other questions? I think there's, yeah, okay.
Hello. Just like to thank the speakers for fascinating sessions this morning. My name is Sam Lonnan and I work for Gloucestershire Health and Care NHS Foundation Trust. I was going to ask, Professor Wilson said about glove use in a side room. Is it time to consider using alcohol hand rub on gloves?
Alcohol hand rub on gloves? No. It's time to consider not using the gloves at all.
Thank you for the response.
It's a funny thing that's happened over the last 20 years since, well, longer than that I've been in infection control. Gloves, you have to really think carefully about what you're trying to achieve by wearing gloves. So people put gloves on. I think what they think they're doing is they're stopping getting anything on their skin. But of course, that doesn't account for the fact that as you remove the gloves, you just transfer what's on the glove to your skin. And there's plenty of evidence to show that actually it's really difficult to remove gloves without transferring organisms onto your skin. The second point to think about is, well, what is the problem about getting pathogens on my skin? So anything you touch, you will pick up organisms on your skin. The point is, the hand hygiene removes those organisms. They don't stay on your skin. They don't really like being on your skin. They are located really superficially. And hand hygiene, whether it be with soap and water or alcohol, and I'm a very big fan of alcohol, will remove those organisms that you yeah, in many forms. Will remove those organisms that you've picked up on your hands. So why would you need to gel gloves? You know, why do you need to wear gloves in the first place? Because actually you can just remove those things with hand hygiene. And even if you were wearing gloves, why can't you just take the gloves off, gel your hands? And if you really need another pair of gloves, so are you having direct contact with body fluid, which is the whole reason gloves were introduced in the first place. Body fluid is very different from touching surfaces and touching skin. When you touch body fluid, particularly fecal material, it clearly contains a high concentration of pathogens, and it makes sense to prevent your hands being contaminated with fecal material or other body fluid that contains high quantities of pathogens by putting gloves on. But that's really the only reason you should be wearing them. And absolutely not thinking of gelling them. If that even occurs to you, what you should be doing is removing them, not gelling them.
Okay. Yeah. Should be on.
I just wanted to add to that, as a really junior IPC nurse, no question is stupid. Obviously everybody, there was a bit of a reaction there, but do ask questions. I think we sometimes forget that things that are really obvious to us in this role are not to our colleagues in everyday healthcare. So actually that isn't a stupid question to ask. There is evidence out there to support why you shouldn't be alcohol gel in your gloves, and contact people to support you in accessing that evidence and understanding it in your role as well.
Yeah.
Just wanted to say.
I think that's absolutely fair enough. And I teach infection control in a master's course aimed at infection control practitioners. And I would say that one of the things I do is a little skills lab where I get students to work through a scenario where they're applying contact precautions. So these are people working in the role as infection control practitioners, and actually they all struggle with, when do I put gloves on? When do I take gloves off? When do I wash my hands? And so, you know, even for those working in the field of infection control, it's really challenging to work through some of these scenarios. And one of the things I try and get my students to do is say, well, take that learning back to the staff that you work with and work through those practical examples together and come up with, you know, a clear practical rationale to underpin practice so that you have a clear idea of when and where you need to use PPE, take it off and decontaminate your hands. So I think that's, you know, a really fair comment.